Okay, so thanks for joining me. The EMEA, the European ME Association, recently released a very long report about conditions for patients with ME in multiple countries across Europe, including a few from the US and Canada, I guess, as well. And so I'm here with the two authors, and we're going to discuss the findings of the report. So maybe perhaps you could introduce yourselves, and then we'll talk about what actually you found.
My name is Trude Schei. I am an ME patient. I've had ME for 25 years. I'm also the Deputy CEO of the Norwegian ME Association, and for the last 10 years, I've been working with large patient surveys.
Okay.
Hi, I'm Arild Angelsen. I'm also engaged in the ME Association of Norway as a board member, and I've participated in a few surveys of ME patients. And my day job is to be a professor of economics.
Okay. So thanks for that. And so why don't you just tell us briefly how the survey came about and what the methodology was?
There's so little research on prognosis for ME, and we don't know how many patients there are. We don't know how they experience the course of illness over a long time. And in 2019, we had a Norwegian survey where around 5,800 patients answered, and we had a lot of interesting findings. One of the things we asked was what factors had affected their course of illness positively or negatively. And we asked open-ended answers and had over 7,000 answers to analyze, and we got a lot of very interesting information. And then we wondered whether the patterns we saw in Norway were the same in other countries as well. So we teamed up with the European ME Alliance, and they helped us getting the survey translated into 16 languages, and the ME organizations in the various countries helped us promote it. So we reached around 11,200 respondents, and I can't remember how many countries, but all of Europe, and quite a few from the US and from Australia and Canada as well.
Let me just correct myself then. I called it the EME Association, and it's Alliance, not Association. So
Yeah.
let me just correct that after the fact.
It's an alliance of European ME patient organizations. We used a platform called SurveyMonkey to spread the survey, and it was anonymous.
And so these were self-reported ME patients or having had a diagnosis, or, I mean, was there a requirement that they had a confirmed diagnosis, or was it the patients were identified as having ME?
We asked whether they had been diagnosed as well, but we know that in many countries it's very hard to get an ME diagnosis. So we also opened up for patients who either were under evaluation or believed they had ME.
Okay. And so the survey was done in what time period?
In the summer of 2021.
Okay, so now it's 3 years, and there was obviously a lot of data that must have taken an enormous amount of time to analyze. So why don't we just go briefly over what, from your perspective, the core findings were and what you would like people to take home from the survey?
Yeah, we have a number of I think, of findings. Some are kind of confirmation that we say we have seen in the Norwegian patient surveys. But I guess the first thing is that ME is a serious illness. Even the mild ME as defined, which is a misnomer, it's mild ME, is also serious because it normally means you're not able to have a regular paid work, or at least not far from full time. About half of them classify themselves as having moderate ME, and 16% severe, and 2-3% as having very severe ME. Very severe meaning that you are not just bedbound, but you're also in need of continuous care by your care providers, family, or others. Also, another thing is kind of this perception, at least among some, that ME is like an illness that gradually burns out. So over time, people get better, they recover, it burns out. And that, at least in our sample, it's far from the case. close to half describe a situation with mainly things are getting worse. They are in
deterioration.
Deterioration, and maybe they are experience a period of fluctuations initially, but then the symptoms are worsening over time. Of course, we acknowledge that there may be a sample bias, so the survey is not reaching those that do get better because they may not be on social media and so on.
Right.
Still, from other surveys, we think that this image of it being a serious, for most people, it is something that they will die with, and not, in some cases, also die from. But it's not, for most patients, something that burn out. Only 7% in the survey reported an improvement over time.
Well, that sort of compares to the figure data we've had for a long time. I mean, I think in the early 2000s, there was a study suggesting 5% sort of spontaneous recovery over a period of time. And you also found an association between deterioration and a later diagnosis, I gather. Can you explain that connection?
And it's one of the very clear, I mean, I'm partly working a lot on statistics in my academic job, and that's one of the very robust association that we find between a shorter period from onset to diagnosis, and the risk of being in deterioration. It's a very strong correlation between that. So early diagnosis is key. And there are also obvious reasons why it is. We know that pacing, keeping your activities within the energy envelope, it's key to increase the probability of a better course of illness. It's not a cure, but it's a type of management that kind of improves your prognosis.
So basically, the idea being, if that is the case, that pacing is not, it's cumulative. Not pacing it sort of exerts cumulative harm, as opposed to just you're staying at the same level, have a crash, and you're back to the same level. But over an extended period of time, not getting a diagnosis, not knowing about pacing, sort of amplifies the effects. Is that the idea?
Yes, and there are also previous studies that show that they identify bad management early on in the disease and a long time from onset to diagnosis as risk factors for severe disease.
Mm-hmm.
So we confirm that finding.
Okay. And so what did you find about, I think access to care was a big issue. What did you find about that across countries?
It was very different from country to country. Norway was one of the best countries. Here, there were only 62% who felt that they got little or no help from the health system. Yeah, only 62%. And many other countries, there were hardly anyone who answered that they had got good or very good help from the healthcare system. And we also saw correlation between the help you got from the healthcare system, the help you got from your family, because obviously they're not getting the information they need, or the help you got from welfare systems and welfare benefits. So the healthcare system seems to influence everything else. Mm-hmm. And there was also a correlation between not getting proper healthcare and a more severe course of illness.
And I think if I may add, I mean, the title is Same Disease but Different Experiences Across the Country. So when you look at disease patterns, kind of the distribution among degrees of severity, mm-hmm. What symptoms are the most dominant, the picture is pretty much the same across the countries. But really the experiences with the healthcare system varies a lot, and that has consequences. There's one article in my field, economics, it's called Ideas Have Consequences. And I think ideas about how how ME is perceived, it has consequences for the patient in terms of their prognosis, in terms of the symptom burdens. And one of the interesting, I mean, many outside Scandinavia or the Nordic countries may think that we are the same, but within the Nordic countries, we have a small table there, how the situation varies, with Norway and partly Iceland being much better compared to kind of the worst case, which is Denmark, which has quite a different approach to ME and some very vocal opponents of a more a kind of psychosomatic angle to the illness.
Yes, we're familiar with those people.
Where more than half of the respondents from Denmark say that they get no support, whereas in Norway and Iceland it's around 15%. So
okay. No support from the medical
from the healthcare system, and at least in Norway there are 16-17% that they get good support or very good support. In Denmark that share is 4%. So there are marked differences, and I think the best explanation is the different approaches chosen. Not saying that it's perfect in Norway. I don't think it's perfect in any countries, but it's in some countries it's even worse.
Well, we can say less bad in cases than others. Yes. Now, what did you also looked at the treatments, and you did something interesting, looking differently at cognitive behavior therapy as a curative treatment or as supportive care, which seems to be the appropriate way, or according to the new NICE guidelines in England, or new from 2021, that supportive care for cognitive behavior therapy is appropriate, but that a curative, with a curative mindset is not. So you looked at that.
Yes, and we found that CBT as a cure does not work, and in most cases it does harm. And the same thing for graded exercise therapy.
Mm-hmm. But there's no supportive role for graded exercise therapy as there is for CBT. So did you find people getting CBT as a more supportive strategy, not as a curative strategy?
Yeah, I mean, one of the key things that we have learned from the surveys we have done previously is that we should make this distinction of CBT as with the aim is to cure, and it's kind of wrong illness beliefs and change those beliefs, and you start on process of recovery versus to cope with the illness. And for a CBT as a coping, yes, overall, roughly a third or even more, 40% found it kind of to be a positive, whereas if you ask about CBT as a cure, we are down to like 5% say that it was beneficial to that. But the large majority thought it was negative. I mean, for those of us who...
Sorry, of those who got CBT as supportive, about almost half, or about 40%, found that it was helpful and supportive. The others found it not really useful, but it didn't make them worse. But with the CBT as cure, only 5% found it helpful, and many more found it harmful.
Yes,
correct. I mean, it's what is it? I have to add up the numbers, but it's 60-70% would say that this had a negative impact, CBT as a cure. And we also find that the more severely ill you are, the worse is it to try CBT as a cure. And also the benefit of CBT as a coping, it's most positive among those that have a mild or moderate degree. Also CBT, try it as a coping. If you are severely or very severely ill, it does on average more harm than good.
Even if it's for coping?
Even for coping, CBT, it seems that the burden, the energy drain that it puts on doing CBT, even for coping, if you are severely or very severely ill, on average, it was more negative than positive for this.
So that was if you did a subgroup analysis of just those people and looked at the CBT in the different ways for just that subgroup, you found it was different across the different spectra of severity or of moderation.
True. So in general, I mean, CBT as a cure was negative for all groups of severity, and the more severely ill you are, the worse was the impact.
Okay.
And you find the same pattern there, but it kind of switches from having, on average, a positive effect for those with mild and moderate degree to a negative effect for those with severe or very severe degree.
Even the supportive.
Even for the CBT as a coping or support strategy.
We've seen this in other surveys, well, where the fact that you have to travel to the treatment and you have to talk to a therapist and travel back home is too much for you. The type of therapy has nothing to do with it.
Oh, so basically the surroundings of what you have to do to get the therapy is what potentially makes it harmful, even if
Yes.
the actual strict content of the therapy itself might be benign.
Yes.
Okay,
Yeah.
I got that.
I think
So
a
how
good
about
interpretation of the findings.
How about with graded exercise therapy? You didn't find such nuances in that as much?
It was bad.
It's more universally bad.
Yes.
I mean, you have some nuances for CBT based on severity and based on cognitive cure. Get graded exercise therapy. Yeah.
But what I find interesting is that we also asked about being active within your energy envelope. And that next to pacing, that was the most beneficial thing. So it's not like we're saying you shouldn't do anything, you should be inactive. Being as active as you can tolerate is a good thing.
I think that's an important point to make, because I think it often gets conveyed that people are against exercise or people are against activity. And it's not really that anybody that I know is really seriously arguing that. They're just arguing that the idea of that's going to get you further is the problem. It's not that, I mean, everybody has to do some activity or should do what activities they can without making it worse.
We also made the distinction between activity that causes repeated episodes of PEM and activity that's within the energy envelope. And activity that caused repeated PEM was seen as being very negative, but being active within the energy envelope was positive.
Were there other, and we've covered quite a lot of ground already, but were there other core points that you wanted to make that you want people to understand about the survey?
Well, there's one interesting finding, and that is that when we look at the people who are severely ill, regardless of how long they have been ill, those who got ill when they were children are overrepresented. So it seems to be very early onset seems to be a risk factor for severe disease. But we don't know why that is and whether it has anything to do with management of the disease or whether it's just the way it is. And of course, we can't say from this survey anything about how many recover, because people who recover would hardly follow an ME website or social media, so we may not have reached those. But there are a lot of people with early onset who are severely ill, and that's worrying. And I would really like for someone to look into it and find out why.
Sort of, I mean, there is sort of the idea that I think that if you get it as a kid, there is a higher rate of recovery. I don't know if that's really borne out by data, but that seems to be a notion that's out there, that there's more spontaneous recovery if you get at a young age. Is that something?
Well, there is one good study from Rowe about prognosis for young people, and they find that quite a lot of people recover, but they also say in the study that they have no objective measure of what recovered means. And some of the people who say they're recovered have lower function than those who say they're not recovered. But at least the prognosis seems to be reasonably good for quite a lot of people who get ill at a young age. But some of them progress to severe illness, and we need to find out why that is. And the other thing, talking about research into prognosis, there are no studies on prognosis for people with PEM. Or one or two studies, maybe, but hardly anything at all. And there's nothing that follows people for more than 3 or 4 years. Right. So we really don't know what the prognosis over a long time period is. And as Arild said, people are ill for 20, 30, 40 years. And there is a huge need for proper research into this. And we really hope that the survey we have done can be a basis for creating hypotheses for research.
Now, you did this in 2021. So do you have any idea of whether some of the respondents are long COVID patients who then got an ME diagnosis? Or do you think it sort of went out and more captured pre-pandemic patients with sort of pre-pandemic diagnoses, or is it hard to tell?
We can't tell from this survey because it takes, as I said, it takes quite a long time for people to be diagnosed. And again, we have the problem that if you don't have the diagnosis, you will not follow an ME support group and you would not learn about the survey. But we are currently doing another survey in Norway where we look at why it takes so long to get diagnosed. And since this is 2024, we're also asking about positive COVID tests and that kind of thing. So we hope to find out.
So besides longitudinal studies, which you've now suggested, are there other recommendations coming specifically out of the report or things that you would like to see happen based on the findings of the report?
Well, I'd like to take back the term biopsychosocial because all disease is affected by society around you and your mental state. And if we say that ME is a biological disease, it's worth starting to look at all the things surrounding the ME patients, like no access to care, financial troubles because you can't get benefits, family that may or may not accept your disease and help you or believe you, dependent on what the healthcare system says. So all of these factors probably make the illness far worse than it could have been if everything had been in place. So I think it's time starting to look at that and see how we can make things better. And
so I want to, I'm sorry, go ahead.
And the hope is that, I mean, those who say that they have had good support from the health system, they report a better prognosis. So, yeah, there's easy things we can do that would make a difference.
Yeah. I just want to say sometimes what seems like interruptions is because there's a time lag. So I've been sometimes
sorry.
No, I interrupted you, or I seem to interrupt you, but it's because there's a little bit of a time lag. So sometimes when I do these videos, it says, David, don't interrupt your guests, but I try to wait. So I wanted to add a public health point, which is that I've always had trouble with in public health, the first thing you learn is social determinants of health. So of course, all the social factors and all the environmental factors impact your health and impact the course of illness. And so it's clear that social factors will exacerbate, or negative social factors, or poor stress and everything arising from having to search for healthcare or not being believed, are going to exacerbate any illness, or living in poor economic conditions, or not having enough for whatever you need, or not having enough money for good nutrition. Those are all psychosocial factors that impact the course of disease. It doesn't mean they caused the disease in the first place. And I think this is where some of the confusion or the distortion of the use of the term biopsychosocial has come in, because when it's used in this context, it seems the bio is mainly forgotten, except because maybe it was triggered by an infection. And and deconditioning is also a biological process, so they can say, oh, it is biological, but that's not really they're not really looking at biopsychosocial in the way that I, as a public health person, think of social determinants of health, which is it's an incontrovertible fact, that poor conditions lead to worse outcomes. So it shouldn't be controversial. But in this context, that term has become highly toxic for reasons that you sort of explain, and why it would be useful to be able to reclaim it as a useful construct outside of the distortion of it that's come about in this context. Does that sort of
in a way, we have confirmed the BPS model, the biopsychosocial model, that psychological factors, how you cope with it, and CBT as a coping is beneficial, at least if you're moderate or mild ME, and that the support you get from family, friends, healthcare, social services, etc., that matters. So it's true. At the same time, we have a saying in science that is too vague to be right or wrong. Of course, these factors matter. That's a no-brainer. But as you say, it has been captured and used in a particular way, suggesting that, say, psychological therapies are a way out of the illness, for which there's no proof. And if you push that line too hard, the P part of the BPS model, you make things worse.
Okay. Any further thoughts or things you want to make sure to get across?
Well, I could just say that we are happy to share data from the various countries with the countries, the ME associations in those countries, so they can use it in their work. And we also invite cooperation with researchers who would like to look at this material. So we make it so it should be used.
Okay. And is there, maybe I'll include a link or something, contact information on the post so people can get in touch, if they need to. I'm just curious, did you find anything distinctive about the U.S. Responses, or different in some kind of way from
The
European ones?
The US responses are slightly different than the European responses. I think, well, that this would warrant further research, because I think it may have something to do with the fact that in Europe, most countries have universal health care. In the US, those who can afford it get proper health care. So that may skew the patterns, because those who are, there may be a lot of people who have ME who are not diagnosed because they can't get to the doctors who can actually do it.
I mean, in the US. In the US.
So we see the patterns in Europe are startlingly similar, but the US patterns are somewhat different.
So that would be the difference in responses to access to healthcare and so on, like that?
I think so. That's my theory, but I may be wrong.
Yeah. Okay. So among the respondents, the US respondents are comparable to the better countries in Europe, but that's those. I mean, if you can't pay or have good insurance, you may get good access to the healthcare in the US, right. Which is, after all, the country in the world that has the highest spending on healthcare per capita in the world.
I mean, it's shame. I mean, we don't have a system. Obviously, it's a pretty shameful situation. And if you have good health insurance, you can doctor shop in a way that's also more difficult, I think, at least than in the UK. So that can be beneficial. But if you don't have health insurance, you're really stuck. So it's a real problem. Okay, well, thanks very much. I really appreciate the time, and I hope this will be helpful for for patients and others who want to hear more about the survey. And we'll get be able to sort of hear about it in a short bite, rather than having to go through the entire 200+ pages of the report. So thanks very much. I really appreciate your time. I hope this is helpful for people watching who can get an idea of what the survey found and sort of the useful things that they can take from it. And thanks very much. I appreciate it.